question for Milana. First of all, thank you so much for your presentation. But I was wondering if in the hospitals there are established protocols for prophylactic distribution once these post-exposure prophylactics become available.
Well, it's not in the hospitals. Nothing has been established right now because these prophylactics are not available right now. But actually, the local public health departments, they definitely have protocols and plans for distributing anything from vaccines to post-exposure. So you would want to look perhaps first under the local public health departments. That's who's going to distribute them.
Great.
Hospitals will have their own programs, but
yeah,
not right now. Yeah.
I have another question actually for you, Milana. Is in terms of, and you mentioned the second wave and what might be coming next. How do you think that will look? And Andrew was talking about it before in terms of those wage workers that are very prevalent in the developing world. Like, are we gonna have to have another shutdown where they're not able to go and make a living? Like, how do you think that will look in the future?
You know, it is possible. I hope not. But it is in the realm of possibilities. That's a similar thing that happened with Spanish flu. I think what we'll see is that it's very likely that the cases will kind of die down. They won't be completely gone, but I think they will decrease significantly over the summer, and kind of there will be a sense of normalcy, and I think people will go back to work as well. But then again, that's exactly what happened with Spanish flu. You know, cases might surge, and then who knows? It is possible we might have to have more lockdowns and quarantines. So something I worry about. And that's why, you know, I love the website idea of connecting people with help. You know, that was really, really good. Kudos on that.
I'm just going to jump in quickly to ask Milana again. So can you talk about the regulatory aspect involved in selling to hospitals? Like if I think one of the hurdles that we are facing is we are working with a lot of organizations to print face shields. However, they're stucking at the regulatory aspect of the bureaucracy involved with selling to hospitals. So there's multiple stakeholders. So my question to you is face shields exempted from FDA approval under, there was a certain section of FDA regulation that I think it was exempted.
No, I hear you. And actually, you know, at Stanford, I know we've had, you know, very generous offers of people from kind of do-it-yourself maker spaces who are offering kind of Stanford, you know, face shields and other things. And we were told kind of by Stanford's dean and Stanford Hospital CEO essentially last week that we can't really accept donations from like at least Stanford can't accept donations from do-it-yourself maker spaces because they have to, it's not just about the FDA approval, they have to be like NIOSH approved. So it's yet another regulatory agency that kind of makes sure that, well, for example, that N95s work as they're supposed to and such. I don't know as much. I think the face shields, but it is a tough, I mean, also in management at Stanford about this. Basically, if people run out, but a lot of other people are running out, they will accept stuff. You know, disaster situation, so kind of we will not kind of.
Can I have Milana complete the second half of it because it was cutting out?
Ask another question till she's back.
Sorry about that.
Sorry, your voice was cutting out in the middle.
Oh, sorry. Yeah, I think like I just temporarily lost the connection. Sorry about that, everybody. So yeah, basically, I think places, if they still have stuff, I think it might be difficult for them to accept things from donations from maker spaces unless they are kind of NIOSH approved. But in crisis situation where like Italy was, for example, then they will start accepting things. That's kind of my general gut sense on this, but I'm not the NIOSH or FDA expert.
Nishat, going off of that, I think that looking at higher density areas that are already in crisis mode, like New York, for instance, hospitals have already started switching. So the protocols now, they're reusing the N95 mask for a week in most hospitals and sticking them in bags, in paper bags. So one thing that you might want to think about is storage for these masks in the crisis places. So if you stick a mask in a plastic bag, all of those viral particles are getting spread all over the bag. And then by the time you reuse the mask, there's a risk that, you know, the viral particles have gotten into the part that's actually in contact with your face, making it more of an incubator than a protector from the virus. The other thing is that these do-it-yourself kind of masks and these, the ones that are not approved by the regulatory facilities, in these crisis areas, some of them are being used as covers for the N95 masks. Mm-hmm. So that might be another way to actually make the mask that you produce usable without having to pass the regulatory restrictions.
Got it.
Yeah, I have a question for Milana. Again, thank you so much for being with us today. Your insight's been so valuable. I'd be curious to hear from you from a sort of an emergency and disaster preparedness perspective, if you could talk about sort of what some of the space needs are in terms of finding space for the additional beds that are going to be necessary as we move towards the peak in the US. Can you talk about sort of creative solutions that have been used in the past to find emergency space as needed?
Oh, sure. You mean the hospital beds?
Yes.
Yeah, sure. So, for example, with Spanish flu pandemics, I mean, they've converted things like gymnasiums, kind of big spaces into hospital beds. I've showed some pictures from Spanish flu. Also, there's a number, I mean, the FEMA, does have some supply of kind of basically pop-up hospitals. And we do, even at Stanford, and I know other places around the country, we have our pop-up tents, kind of with pop-up beds that we can have. So physical space, we have some, it's limited, but we have some. And again, you can also kind of figure out, not everybody needs like hospital level care. Maybe some people who are maybe less sick, they can be managed at home, but maybe if you give them oxygen tanks, I mean, for example, because it's not like everybody needs an ICU or not. I mean, I think there's a whole spectrum that can be thought about creatively with also treating patients in their homes by giving them, by telemedicine, let's say maybe giving them oxygen, for example, for more minor cases, but which are actually more prevalent than kind of the very severe cases. About 15 to 20% of the patients with COVID get admitted to the hospital. Maybe that number could be halved if people had home oxygen. About less than 5% of the people who go to the ICU, obviously those people need to be in the hospital. So I feel like creative use of spaces, we've looked at, kind of telemedicine, assisting people from their cars, because also, for example, in the ER, we face the situation of somebody COVID infected goes in our waiting room, they can infect others. And then, it's a huge hassle to clean and just takes time and resources. So any kind of creative approaches to contain the infection while also providing resources is helpful. But the thing is, everybody thinks, let's just build more hospitals. The truth is you can't have pop-up doctors, pop-up nurses, pop-up respiratory technicians. It's not just about the ventilators, it's also about the people who know and are experienced in operating them. So it's not kind of as simple, but I think, there's definitely room for creative allocation of resources and telemedicine use and other things. Yeah, because I mean, we're not dealing with the Spanish flu pandemic. I feel like we should use modern tools, which we are leveraging much more heavily than kind of historically has happened.
Thank you.
Yeah, totally.
I had another question that was related to that. In the initial call, it sounded like one issue, at least in the UK, is that a lot of hospitals, like people are getting better, but because they're still contagious, they don't want to release them back home where they could potentially spread to more people, but they don't necessarily need to be in the hospital. And so I was just thinking there's a bunch of like empty hotels and dorms in most cities now. Could that be kind of like an interesting creative useful solution?
Yeah. Absolutely. I mean, people are definitely looking at that. And by the way, to the prior question about how to use space, actually, Stanford is even thinking of utilizing dorms as hospital beds. Now the students are not there. maybe putting some, like for example, maternity wards and, some other things, even utilizing dorms. And because again, spaces in colleges, a lot of people are teleeducating now in colleges, and absolutely. And that's actually, as far as using hotels as spaces, that's what they've done actually in South Korea and also in China. In the US, people tend to self-isolate at home. But actually in some other countries like South Korea, they don't, a lot of these people actually refer to other facilities. So they say, you cannot go to your home because then you can infect your family members and others in the community. You go to this other place and you sit there for 2 weeks. So absolutely, people are definitely thinking about it and looking into it. And now, especially, there's all this extra capacity because people are not traveling. So yeah.
And then one other question to kind of follow up on that. You were talking about how space is maybe not the key constraint and actually medical talent is a bigger issue. Are people thinking about ways that they can kind of like remotely train people to perform tasks that are maybe like require less knowledge? Like, I don't know if there's parts of like nurses or doctors' jobs that could actually be done.
Yeah, I mean, we're doing all that, not all that, but we're doing a lot of that at Stanford. I know other people are too. For example, we're trying to repurpose our surgeons to take care of patients in the intensive care unit, just as an example, or train people in how to operate simple ventilators who are not previously trained. So things like that. I mean, there's definitely a movement to do that.
Are there ways to volunteer to, I mean, even if you don't have a medical background, to maybe help out with like tasks that are more simple? Because I think also so many people are, unemployed now.
That is true. You know what, what I can say is I'm not aware of any specific initiatives, but I think there's definitely room there for kind of thinking around that. Because the truth is, as our capacity gets increased, they will have more needs for volunteers or maybe kind of quick up ramp. And this kind of goes back to what I mentioned about regular care versus crisis care. Regular care, we have everybody trained, everything is NIOSH approved, all the equipment is NIOSH approved, versus population care. We have to do with what we got, and so, yeah, in that case, then that's going to be all hands on deck. And, we're kind of heading there. They were there legally. So
yeah, like interesting stuff that could be done also with like remote learning. And I don't know if people are building like tech tools to help facilitate that.
Yeah, I mean, we see a lot of that. For example, I know there was a project Echo, and this is kind of like an open source educational tool that was just launched last week out of University of New Mexico, which is basically, for example, doctors in New York are giving ran rounds about their experience treating patients, or people in Italy who've kind of already experienced this outbreak, kind of educating others, and everybody can join. So that's for the doctors, and I'm sure there's things like this for other professionals like nurses and allied health professionals. But I think there's definitely a lot of room there for improvement. Yeah, no, it's definitely an interesting question. But again, also, I mean, sorry?
Sorry, please go ahead.
No, and even actually training people how to take care of their loved ones at home. I mean, I've heard about the maker spaces. Some people are like, well, can we just like make a bunch of, can we do like oxygen generators? So like they're taking air and like basically generating oxygen, so you don't even need kind of a supply of oxygen, and giving that to people's homes. So if you're a milder case, and you can kind of hold off at home, so really that could decrease the load on the hospitals. Maybe training people how to administer that. So there's definitely a lot of room, I feel like, in that domain as well, where it's not purely medical, but it's kind of on the spectrum. Yeah.
There could be a cool initiative that combines those two aspects, basically in-home oxygen generators with training programs essentially for family members. And then also within that training program, we could probably have like a specific diagnostic for when the hospital is needed. So a protocol for deciding when that's required. I think that could have a super
yeah, I think that's really interesting. I mean, I could connect you, I know somebody who's actually trying to design, this, he's an engineer, and he's actually designing this oxygen generator, or whatever it's called. So yeah, he's local to Stanford, so I could, I'm sure he could like use some help like thinking about it and kind of moving this forward. So yeah.
That'd be
How
I mean, it's not going to be like a hospital. It's not going to be like FDA approved. I mean, but again, in a disaster situation, people might end up relying on that. Who knows,
Yeah. How short supply is just oxygen right now? Because you hear a lot about ventilators and masks and stuff. I haven't heard about oxygen.
Yeah, well, I mean, I think oxygen is okay because there's so much of it for commercial uses. So people are now talking about kind of taking the stuff from commercial uses and doing it for medical. But then there are all sorts of kind of safety issues around that. How much you want to make sure like people don't blow up, I mean, it's just, it's, there's a lot of kind of fine line there. It's not an easy transition from kind of commercial use oxygen to home use oxygen. And also the thing is you have to think about transportation and oxygen tanks, and these things are under pressure. So maybe like alternative things like creating like an oxygen compressor, which is not going to like overwhelm people quite as much, maybe more optimal. But again, these things are probably not going to be quote unquote FDA approved, but hey, in a disaster situation, we might have to do with what we have.
Yeah.
Yeah.
I have a question for Dr. Milana. So how are resources being allocated between hospitals as of right now, in terms of ventilators, I guess?
Ventilators specifically? Well, I mean, it's quite frankly, I mean, so in the US, it's it's run by private industry. Hospitals are private industry. So it's basically kind of, for the most part, each man on their own. So hospitals are have their own ventilators. I know Stanford has a stock of some kind of smaller ventilators as well that they use for disaster purposes. Some hospitals might be better prepared. Some hospitals might not be as well prepared. I know that there are some ventilators. The U.S. government has access to some kind of emergency surge ventilators, but these numbers are limited. But that's kind of, this is the same for ventilators and other personal protective equipment. It's kind of the job of the hospital and the healthcare system to buy their own stuff.
Right. Would something like a national ventilator registry help at all?
It's an interesting point. Honestly, I don't know, but I like how you're thinking. Yeah. Because I like how you're thinking because maybe, maybe like places where it's more controlled can share with places that are less controlled. I mean, I know It's interesting in China, actually, now that China has this far more under control than us, we're getting, there's a lot more resources opening it up for PPE because they've mass produced all this personal protective equipment they're trying to offload, essentially. But it's an interesting idea. I don't know the answer to that specific question, but maybe worth looking at. I anticipate there may be some issues because it's not a public system. If it were a public system, it would make a total sense to do that. But since it's a private system, I don't know how I don't even know if hospitals could transfer their ventilators from one to another, to be perfectly honest with you. But maybe if you involve public health department, that might make more sense. So maybe worth a conversation with them.
Okay, let's maybe take one more question if we have the last one.
Hello. Yeah, can I ask? So on the ventilator front, for example, in Stanford, is there currently an expectation of a shortage? And what were these smaller ventilators that you mentioned?
Yeah, no, right now we have more ventilators than we have ICU beds. And that's even after we scaled, because we close to doubled our ICU capacity at Stanford. And our ICUs right now, they're not full. I mean, hopefully they will never be, but right now, at least we're doing okay. And the smaller ventilators, actually, that's something, I don't know which ones Stanford has specifically, but I know actually Stanford by Design, this was a project out of Stanford by Design where Mike Callahan, who's actually was one of the fellows or one of the residents here at Stanford a number of years back, developed this compact ventilator for kind of these kinds of scenarios. I don't think that's the kind of ventilator Stanford is buying, but I know Stanford has some extras that we can pull out and use.
But these are invasive systems or non-invasive?
Invasive.
Or does that matter?
Yeah. Yeah. These are invasive systems. Yeah. And by the way, speaking of non-invasive, I mean, when I mentioned spectrum of care, I mean, there's also a lot of opportunities where when success have been shown in Italy and other places with people using non-invasive ventilation like CPAPs. And that's much, you know, and you can train kind of people at home to use them, because at home members, you know, family members can use them for their family, for their loved ones. So non-invasive ventilation, again, talking about the whole spectrum. It's not just the ventilators, it's the CPAP.
These, for example, might help prevent the deterioration, is that correct?
Yeah, I mean, they give you oxygen more effectively. So yeah, they can save your life.
But has this been tied to prevention of deterioration, or is it that one class of patients this may be sufficient for and another class of patients this may not be sufficient for?
Well, I mean, I'm not, so as far as prevention of deterioration, if somebody doesn't, they don't necessarily kind of prevent the deterioration of disease organically. So it's not like they're going to cure you or not, or help you to not, you know, have virus multiply in your body. But the whole point of these supportive measures is essentially to prevent you from dying while your body is undergoing a natural course of the disease. So that's kind of the point. So they won't prevent the deterioration in that sense, but they will prevent you from dying. So that's deterioration as well. So they're there to support you, to support the breathing factor, the oxygenation while people are fighting the disease. I don't know, does that help?
Yes, thank you. Can I contact you offline maybe on
Yeah,
something?
sure.
And then just in terms of the scale question, right, a lot of the concerns have been that this has been an exponential growth. So is that in consideration? I don't know exactly how many.
Well, it is exponential growth, yeah, right now. I mean, right now it is, but, you know, we're trying to make that growth not exponential. We're trying to take the R naught to much less, you know, to less than 1 in order to start controlling it. So now that the fact that not everybody, but a lot of people in the lockdown, that's kind of what takes it from exponential growth to normal growth, and hopefully to start decreasing the spread.
The hope is to decrease the spread in order to, the hope is to decrease the spread in order to make the ICU capacity sufficient. Basically, that's
exactly. Yeah, it's just you're trying to match supply with demand.
Because I've seen some cases, I don't know about Stanford specifically, where the ICU bed numbers are not large, right? So they say something like, we have 5 patients right now, but we have 50 beds, so we're still good. But, you know, I'm not a doctor. I come more from the mathematical and computer science side, right? Under exponential growth, those 50 beds could be very quickly, right?
Exactly.
So that's
the
question. So.
Yeah, you got it. You got it. That's exactly right. And that's why people are jumping on this now rather than later, because after, when your ICU beds are full, you know, it's going to go like this even more. So that's why, you know, that's the point of lockdowns, you know, before that happens. So you're absolutely right. So it's not, so yes, it's exponential. I should clarify, it's exponential threat spread unless you take aggressive measures like lockdowns or quarantines, in which case it's no longer exponential, it's linear, or even, you know, the R naught is basically 1 and less than 1. Start getting this thing under control.
So thank you so much for all your questions. I think
is there any chance I could ask a quick question? I know we're short on time, so if not, that's okay.
Go ahead.
Defer to Dr. Trounce.
Thanks so much. Sorry, I can also take this offline if that'd be better. But a last thing I was wondering is I've been hearing a lot about like sanitizing and reusing PPE. And I'm curious about like how well equipped hospitals are to facilitate that. Like, do they have like sanitization strategies like industrial UV lights or something like that they can use? Or is it the idea that people would like buy this themselves and do it at home? Or like, how is that kind of developing?
Yeah, no, great question. Something we're looking at right now. Stanford is not doing it because they have enough PPE and because it's this sanitizing N95s is technically not NIOSH approved. And so we're not exactly there. And this actually, I had conversations about this with Stanford Task Force on this yesterday. So, I mean, Stanford definitely has, you know, they could do it. I don't know, you know, not necessarily with UVC lights, but they could, you know, they could do it. they have the capacity. That doesn't apply everywhere. For example, one area we're working with is we're working with emergency medical responders. For example, EMS systems, your paramedics, they don't necessarily have the setups. You know, they might, we're talking to, you know, their medical directors, you know, is it worth putting in some kind of ovens or something where we could literally bake those N95s for 30 minutes and then basically reuse them. Again, this is not NIOSH approved. So this and the CDC just released their guidelines on this actually April 1st. So you can look at their website as to exactly what they recommend. You may have seen this. Yeah, so hospitals have this, but a lot of other places like nursing homes or EMS systems, people can do it in their homes. You know, I mean, there's been a lot of hoarding of N95s, and I think if people know how to reuse them, you know, you can just stick them in a paper bag, wait for 5 days, and you can reuse them because the virus only lives for up to 5 days on plastic surfaces. Like, you're done. Or if you just have one, like, you know, bake it at 30 degrees for, you know, for 30 minutes at 70 degrees, as long as it doesn't touch any metal. So there's definitely a lot of room there. So don't think of it as for innovation around that as only hospitals.
Great. And I think so any remaining questions we can probably like move to offline. Sure. And thank you so much for all your questions. That was super helpful for all of us. And I did just defer to Josh to close the call.
Yeah.
Yeah. Thank you so much. Thank you so much, Milana. This has really been amazing.
Oh, thank you guys.
Yeah,
no,
thank
you
you.
guys have been amazing. Thank you for taking the lead on everything. I know, you know, it's exciting. It's inspiring what you guys have been able to do even like in a week. And I'm really looking forward to see it grow, and I'm happy to help and put you guys in touch. And